Hi everyone. Our topic of discussion is the fungal infection called sporotrichosis, which is also known as Rose Gardner's disease. So the organism that causes this infection was first isolated in 1896 by a medical student named Benjamin Schenck at Johns Hopkins University, and it remained unnamed until 1962 for almost 70 years because of challenges involving its classification. And it was around 1962 when more of its characteristics were realized, such as its dimorphism, and it was finally named Sporotrichosis. This fungus is commonly found in soil and certain plant matter, and therefore especially affects individuals that are more likely to come into contact with them. It enters through openings in the skin, such as a cut or a scrape, and the infection takes on a characteristic lymphocutaneous lesion, which appears as abnormal and colored marks on the skin along the lymphatic vessels. Sporotrichosis is the most common subcutaneous fungal infection in the Americas, Japan, India, and South Africa. A fairly recent epidemic occurred in the US in 1988, where 15 states were affected by this infection because of an outbreak that began in areas with sphagnum moss in Wisconsin. Since this outbreak, there has been about 200 to 250 cases in the US every year, and it affects 1 out of every 1,000 people in Peru. Cases of sporotrichosis have been reported in every continent, so it is globally prevalent, and epidemics have also occurred in China, Australia, and South Africa. From 2000 to 2013, the hospitalization rate for sporotrichosis in the US was highest in the western regions, while in the northeastern regions, the rate was the lowest. Within these years, hospital stays associated with sporotrichosis were also more likely to be longer, about 7 days, as opposed to the average stay of about 5 days. The cost for these stays, with sporotrichosis-associated stays totaled at about $36,000 per case, were also more likely to be more expensive than the average, which was about $26,000 per case.
The causative agent for this disease is Sporotrichosis, a fungus. Fungi are eukaryotes with chitin in their cell walls, which is there for structural support. This organism is classified under the phylum Ascomycota, with many other medically relevant fungi. S. Schenckii is a saprophyte, living on decaying material. It is closely related to other Sporotrich species, which cause similar infections in humans and cats. The spores of this fungus are conidiospores, a type of asexual spore. The conidia for Sporotrich schenckii look pretty like flowers. The infection does not look pretty. We'll get to that later. Sporotrich schenckii is considered a dimorphic fungus because it takes two forms, the hyphal form in nature or when grown in a lab, and the yeast form, which is assumed inside its host or upon reaching a temperature of 37 degrees. The gray picture is the yeast form taken with a phase contrast microscope. You can see the elongated buds on a narrow base. This fungus mostly dwells in soil, but can also be found on rose bushes, sphagnum moss, wood, hay, and other decaying plant matter. Animals can also be carriers, especially cats and armadillos. If that weren't enough, you can also find S. schenckii in water, insects, and hair. In the lab, its optimum growth temperature is between 35 and 37 degrees. That is, body temperature. Virulence factors include melanin, adhesion to proteins in the host's extracellular fluid, and various substances to guard against immune response.
The primary portal of entry for Sporotrich schenckii is the skin. That is, if the skin is open or becomes open, for instance, if a branch that is housing the fungus scrapes against the skin, enough to form an opening for the fungus to enter. And from the skin, it moves along the lymphatic vessels and in more severe cases to the bones, joints, and viscera. In rare cases, the spores of this fungus can be inhaled, and this route of entry tends to affect immunocompromised individuals.
Sporotrich schenckii can cause a pretty nasty infection that has the potential to affect many tissues in the body. It affects cutaneous and subcutaneous tissues. Because of direct contact with fungal spores, hands, arms, and legs are most commonly affected, with the cutaneous and lymphatic vessels also damaged. As it progresses, ulcers also affect the dermis and epidermis. In the fixed cutaneous form, facial tissues can also be involved. Mucosal sporotrichosis occurs when the patient touches their face with spores on their hands, especially the nasal septum and conjunctiva of the eye. More reason to not touch your face. For immunocompromised people, bone tissue is the second most compromised after the skin. Sporotrichosis affects joints, especially the knee, wrist, elbow, and ankle. Inhalation of spores can damage lung tissue, particularly in the apex of the lungs, where it forms lesions and cavities like those caused by tuberculosis. Rarely, the nervous system is affected, particularly the meninges, and sometimes it causes abscesses in brain tissue. Virulence factors. Many of these are still under investigation. Having said that, a few factors stand out. Melanin is a protein found in our skin, but in fungi, it helps them survive in difficult environments such as extreme cold. Melanin may also be responsible for resistance to antifungal drugs and being consumed by macrophages. Another virulence factor is adhesion to epithelial and endothelial tissues. Both forms of S. shankiae have adhesion lectin molecules that are able to recognize and stick to proteins on the host cell, like fibronectin, laminin, and type 2 collagen. This aids in initial infection as well as the fungus's ability to spread. Nitrogen reduction may also help this pathogen to be resistant to oxidative stress and antifungal drugs. Sialic acid on the cell surface helps protect against phagocytosis by the host, and so do proteins such as galactomannan and rhamnomannan. Other virulence factors interfere with the host's immune system, such as protease and exoantigen. Transmission by alternative hosts like cats may lead to more humans being infected. There have been increased cases of animals that do not show signs of infection, transmitting the fungus to humans via scratching, biting, and stinging. Sporotrichosis takes several forms. The most common is cutaneous sporotrichosis. That occurs beneath the skin where the fungus first entered the body. It is usually a small bump that does not cause pain. Eventually, this bump grows into an ulcer that drains pus. Other bumps and ulcers may arise and can actually remain for years. In over half of patients with this disease, the infection can spread up the limb via the lymph nodes and is classified as lymphocutaneous sporotrichosis. Other forms of the disease that affect the mucosa will result in bloody nasal secretions and swelling of the eyelid, redness, and drainage. Patients with pulmonary sporotrichosis often have a cough, fever, difficulty breathing, and chest pain. This fungal infection makes underlying health problems even more serious. Patients who are immunosuppressed, like people living with AIDS or chronic alcoholism, can develop a systemic infection. This is called extracutaneous or disseminated sporotrichosis. Symptoms can be confused with rheumatoid arthritis, like joint and bone pain. If the infection reaches the nervous system, the patient may experience headaches, seizures, and confusion as the meninges and brain tissue are affected. Among patients living with AIDS, the mortality rate for this systemic infection is estimated to be as high as 30%. For diagnosis, a doctor takes a biopsy of tissues or pus from lesions, and a culture is grown on saburad agar. Sometimes an ELISA assay is used in diagnosis. More serious cases can be diagnosed by testing blood, synovial, or cerebrospinal fluids. Also, infected tissue tests are performed, where Sporotrix yeast can be seen in clusters.
Because Sporotrix shankiae enters the body through openings in the skin, it is recommended that gloves and long sleeves should be worn to protect the skin, especially by those who come into frequent contact with plant matter. There are currently no vaccines, and treatment and therapy are determined according to where the infection occurs and its severity. The universal treatment for localized infection is itraconazole, which is an antifungal drug that inhibits an enzyme that enables ergosterol, a crucial component of the fungal cell membrane. By inhibiting ergosterol, the cell membrane of the fungus breaks down and survival of the fungus is compromised. Itraconazole is expensive, but it is reportedly known to have a success rate of 90 to 100%. Supersaturated potassium iodide is a low-cost alternative to itraconazole, but risky since its mode of action is not definitive. For instance, it is theorized that the host's defense is open to the infection through this drug, but few conclusions have been drawn. Side effects are also very severe and can lead to conditions such as pulmonary edema, hyperthyroidism, and myalgia. However, it is the drug of choice for uncomplicated cutaneous sporotrichosis. Amphotericin B is an intravenous drug used in disseminated cases when the infection spreads to other parts of the body. It creates autooxidation in the cell membrane of the fungus and releases free radicals to kill the infecting cells. These free radicals are also lethal, however, so it is administered usually in the beginning phase of therapy until conditions improve, and then treatment is switched to itraconazole. And lastly, surgery may be necessary if the infection spreads in close proximity to viscera, such as in lung tissue.